I am going to present a case of a bilateral complex primary TKR. 59-year-old female who had a severe both knee pain for long duration, difficulty in walking with gait instability. She had no comorbidities. Right knee had a valgus deformity with hyperextension deformity, mediolateral laxity, flexion minus 10 to 100. Left knee had varus with fixed flexion deformity and 90-degree flexion. These are the AP lateral and scanogram X-rays. She had 34 degree of valgus on right and 22 degree of varus on left side.
Okay, so let's stop there. Thorsten, let's start with you. How are you going to tackle this problem?
If I have a 3+ medial insufficiency, that means the medial collateral is almost gone, then I would directly go for hinge knee on the right side.
Okay.
On the left side, you can do what you want.
Okay, anybody have anything they want to add? Rajesh?
I would not automatically go to a hinge. Even this might, at the end of cuts and balancing, you might need a constrained one, not just the PS. But yeah, I would agree that a hinge has to be on the back.
Does anybody have any other concerns about the knee? And
clinical examination is again important, that when you give a valgus stress, you have to see that whether there is a, you have any, it's a opening up quite easily, or there is some restraint there. So that gives you an idea about the, whether the MCL is functional or not. I would keep on the table, constraint is ready, but on the table I'll decide about whether to go for a hinge.
So the question I have though is there any concern for why this patient has this deformity? Is anyone concerned about a Charcot knee or a neuropathic knee in this situation?
Yeah, I think it's always good to eliminate a neurological condition, especially if there's hyperextension. Was there hyperextension on the valgus side?
Yeah, he said there was, on the right side, not on the left.
Yeah, so on the right side. So I would be really concerned that there is a neurological component to it. If it is a neuropathic joint, then perhaps Thorsten might agree that a hinge may not be the best option. You'd rather use a TC3 rather than a hinge.
Yeah, Arun, that's right. So it has to be a special hinge knee. It has to be a pure hinge knee. But again, I agree with you. If it is a neuropathic one with hyperextension, a hinge knee is probably not the best solution. That's a very good comment. Then you need a very special hinge knee with a big bumper, or you use a CCK or VVC.
So that's an excellent point that I wanted to bring out, which is not all hinges are the same. And some hinges are designed with extension blocks to prevent hyperextension, and some aren't. And if you put one that is not designed for it into this kind of case, the locking mechanism will break. And then you have a big problem, especially if you've cemented stems up and down the femur and the tibia. All right, keep going with your presentation.
So patient preferred stage-wise surgery. So I did right knee first. I used lateral parapatellar approach, and proximal tibia and distal femur cuts were taken under navigation guidance. Lateral pie crusting was performed, and next-gen PS implant with 17 mm insert was used.
All right, so let's stop right there. Thorsten, yeah, go ahead.
One short question. Do you think that a PS design can correct varus valgus deformities? Because you used a PS design here, there was a valgus deformity. Do you think that the PS can do it? PS gives you more security or more safety?
Actually, I always use PS implants. And since as the surgery progressed, I could get a good mediolateral balance. So towards the end of the surgery, the medial collateral ligament was tight enough to balance the medial compartment. So I preferred, because in this case, I had kept LCCK and RHK as a backup. And I was planning to use if needed. But during the course of surgery, I could get good balance, so I stopped with PS.
The MCL was better, much better than you expected, and much better than you has shown us in the pre-operative. Okay.
Yes.
So,
Have you taken,
key messages that you're trying to make, I think, using the least amount of constraint is generally a good, philosophy to follow. But we were also discussing that the patient had hyperextension, and some knees are at increased risk for developing late onset instability. And this might be one of them. And so even though it was balanced with the PS, you might have been better served having that backup in there with a constrained knee for, like I said, for down the road. Especially because this knee also has been left in a little bit of residual valgus. We don't have the full length x-ray, but...
I have post-op full length.
Okay, so why don't you show us that?
And left knee was operated 1 year later, routine medial parapatellar approach. And this is the scanogram at 6 years follow-up.
All right, you got lucky that she had a lot of ventrolateral bowing of her femur.
Yes.
How much bone?
Just one point on this. When you look at these films and you start assessing the medial collateral because you think that it's elongated, a lot of these deformities, because of the sort of bone loss that occurs on the posterior tibia, you have a rotational deformity occurring at the level of the joint line, and that seems to give you an impression that the medial collateral is extensively stretched out. That may not be the case, and you may end up being able to balance the knee because it is intact.
May I ask a question? How much bone cut did you take?
I took very thin cuts for the right side because when I put the navigation system in, it was hardly cutting 1 or 2 mm from the lateral femoral condyle, distal lateral femoral condyle. And since it was 2 legs, you can see the level of resection on the tibia is also significantly higher than the fibula head. So I took very conservative cuts.
And, and that's a take-home message for the audience. Whenever you see those preoperative x-rays where there's medial stretching or lateral stretching on the other side, those are knees where you have to start off with very thin cuts, thinner than you normally would cut. Because otherwise, you still used, looks like 15, 17 millimeter polys, and you had thin cuts, right? So that's the risk when you have stretching of a knee preoperatively.
Yes.
But, okay, and you had some 6-year follow-up. Well, that's fantastic. All right, any other comments or questions from the panel?
the pre-op, we should get a varus correction x-ray. That give you a good idea about how much correctable it will be on table. If it is fixed, then it becomes difficult. He hasn't shown any pre-op varus correction x-ray in the coronal plane.
I'm sorry, what do you want? You want pre-op?
Pre-op varus correction x-ray for the valgus deformity. If it corrects significantly, then you know that you probably may not need anything more. The balancing will be easy.
Yeah, so
That's
I mean,
one of the
but
things
do you need an x-ray for that, or can you just do that by clinical exam?
We can take it on clinical exam, but if you take an x-ray, it may be just records exactly how much correctable it was.
So that's a medical legal, issue to make a recording of it. But you don't need that information to do the operation and to, you're
On
trying to
table
determine, is it
yeah.
correctable, is it partially correctable, or is it fixed, right? That's what you're trying to figure out. And, you have to make sure then, is it because it's a soft tissue problem, or is it a bony defect problem, or a combination of the two, right?
It helps your surgery.
Yeah,
And always take a skyline view, operatively.
100%.
Thank you.